and visible now?
Yes, sir.
Yes. So organophosphorus compound poisoning. This was one of the commonest poisoning method happening either due to the professional job of the farmers spraying these organophosphorus compounds in the fields to ward off the unwanted insects and other things spoiling their growth of the fertile plants, or it was the main source which was easily available, can be bought in the shops where they sell the manure and other pesticides. So villages, it is a very common mode of committing suicide. People intentionally take this. So the mode of organophosphorus poisoning in the earlier days used to be suicidal and rarely because of unintentional exposure. And after so much of education by various other NGO groups and the government, people were advised to wear a mask or cover their nose and keep their body fully covered without exposing the skin, because this poison can enter our body through three routes. One is by inhalation route. It can enter through your lung, it can enter through your skin, or it can enter through your gastrointestinal tract if you consume it intentionally or unintentionally. So because of all these routes of entry into the body, one has to be very careful to avoid the drug entering our body, which is a main action of this compound is to suppress the cholinesterase enzyme which is present in our body. So what happens is when you suppress the cholinesterase, the normal acetylcholine that is very importantly produced in our body for our neuromuscular transmission is not metabolized or broken down. So there is a acute cholinergic crisis like thing happening. So acetylcholine goes on accumulating because the enzyme is not able to break it. So whenever it is like a massive parasympathetic stimulation, because the excess acetylcholine acts on its receptors. Two types of receptors where acetylcholine acts, all of you know, are asternic and nicotinic actions. And it is also a main important transmitter in the central nervous system. So the main actions happen because of the massive stimulation of muscarinic receptors, nicotinic receptors, and the central muscarinic receptors. So all these things produce the symptoms on various organs, especially the glandular secretions are all enormously increased. So we had a toxicology unit and we were treating all poison cases in Stanley for over 15 years in the earlier stages. And we used to receive a lot of these patients from the nearby villages. And we have seen cases coming with florid froth in the mouth and nose, looking like a pulmonary edema. But it is not pulmonary edema, it is the rhinorrhea and bronchorrhea, which is coming out like a froth. So you keep on sucking it, it will well up within no time. So that much of secretions one has to see to believe that severity, and that will cause a lot of cardiovascular, respiratory, gastrointestinal, and central nervous system effects. And if not treated within the required time, the poison, the drug, the chemical will get fixed to the acetylcholine enzyme, cholinesterase enzyme with irreversible manner. Then it is very difficult to separate that bonding, and the effect will take a longer time, and you have to keep on supporting them with the respiratory and cardiovascular systems so that you can avoid the morbidity and mortality. So earlier patient arrives and then you start treating them, it has a very good result that it can save the patient, and that is a very important thing in the treatment of this compound poisoning. So they bind irreversibly to the acetylcholine stream in the plasma, red cells, and cholinergic endings in the central nervous system and peripheral nervous system. So how do you classify these compounds? They can be highly toxic organophosphates like tetraethyl pyrophosphates or parathion. So there are two types. One is called parathion, the other is called the malathion. They are mainly insecticides used in the agricultural people. So the second is intermediate toxic phosphates, which are used in animal insecticides in the veterinary field. And third is the low toxicity. We still use some cockroach and fly repellents in our household now also, but they are very low toxicity ones like diazine, non-malathion, dichlorobor, all these things which come as flick and other things which we commonly use in our household. Now, how to classify the effects of organophosphate compound and which symptoms occur most? This is first we mentioned. The acute symptoms and signs are due to the muscarinic, nicotinic, and central receptor effects. And the peripheral muscarinic symptoms are due to actions on the relevant glands, with central muscarinic effects resulting in confusion, coma, and convulsions as a central nervous system effect. The nicotinic effects are motor and sympathetic, resulting in fasciculation, muscle weakness, and tachycardia and hypertension. And muscarinic symptoms and signs were the most frequent. That is the bronchoria, rhinorrhea, gastrointestinal cramps. All these things are the most frequent symptoms, and that occurs at about 84%, followed by the central nervous system effect. That is the confusion, coma, and convulsion. And the nicotinic effect, which is the tachycardia, muscle weakness, and hypertension, is the lowest presentation. And the time-based approach is very important because they can be classified as the symptoms occurring within minutes to hours, which is called acute. Then there can be a delayed or late which occurs. This delayed or late occurrence of symptoms happens in the farmers who spray this without protective gear. So they inhale that and gradually become weak and tired. In them, the nicotinic effect will be more than the muscarinic effects. So the delayed effect happen because of the agricultural profession where they get exposed to these insecticides. And the symptoms were categorized as organ specific. Can be neurological, cardiac, respiratory, or GI tract manifestations. Now, what is the mechanism? How does it affect the cardiac, the enzyme? They do what is called acid transferring inhibition of cholinesterase. So what acid they cause cholinesterase to become firmly and irreversibly phosphorylated, which is means that it will get bound to the enzyme and not separated. So they inactivate the enzyme by getting bound to that. And if I show you the picture, it will be easy. And reactivation in a smaller quantity inhaled, it will be the enzyme will be able to remove the binding and get reactivated spontaneously. But the rate of reactivation depends on what type of the poison that entered the body and which tissue is affected and which chemical group is attached to that, which is the main important thing. And the reactivation is done by the method of hydrolysis, where the acid radical is broken through the use of oximes. Also, you can do that as a treatment part of it. So if you see the acetylcholinesterase enzyme, it has got two sides. One is called the anionic site. The other is called the esteratic site. This is the normal structure. And this is how it is breaking the acetylcholine enzyme also. Getting attached to the anionic and esteratic site, it breaks the acetylcholine into acetic acid and choline. That is the normal way this enzyme is supposed to act. But when it is exposed to the organophosphorus compound, free in the presence of organophosphate, the organophosphate gets attached here. You can see this is the phosphorus compound and this is the serine astatic site, and here this is free. Now organophosphates attached to the astatic site. This is the organophosphorus compound chemical, that symbol is there, and the anionic site is free. If the organophosphate molecules lose its alkyl group, it becomes resistant to hydrolysis, that you cannot break it down, and this is called the aging. And when you give this oxime, pralidoxime, which is supposed to be a reactivator, it breaks the phosphorus atom here. That is, the binding here is broken down, and so then it becomes easily removable by hydrolysis. So the astatic site where the organophosphate gets attached, it acts at the phosphorus level. So pralidoxime has a quaternary nitrogen which attaches to the anionic site, and then it oxime reacts with the phosphorus atom attached to the astatic site. So first pralidoxime will attach to the free anionic site, then it will cleave this binding here and oxime phosphonate. So this takes the phosphorus back to itself and diffuses away, leaving the enzyme free for its normal activity of breaking down the acetylcholine. Okay, so when the phosphate is attached, there is nothing here. This anionic site is still free. That is where the pralidoxime has to come and get attached and then break this binding of the phosphorylated organophosphate to the serine or astatic site, which will make the enzyme get released or reactivated. That is how the whole process takes place. Now, what is the pharmacokinetics? Organophosphates are very highly lipid soluble compounds. So, all lipid soluble compounds can enter the skin or oral mucosa or gastric system or respiratory tract very easily. They get redistributed. They are found in liver and kidneys also, and they cross the blood-brain barrier. That is how they are able to produce the neurological effects also. And the metabolism is by oxidation in the liver, conjugation and ester hydrolysis. And the oxidative metabolites of malathion and parathion are also active and subsequently hydrolyzed into inactive metabolites. So that is the reason why their effects are all prolonged. Even though you try to treat them initially, all these patients with organophosphates have to be in the hospital for reactivation or something like the residual polarization causing a muscle paralysis after recovery from a neuromuscular recovery after a neuromuscular blocking agent. Delayed effects can happen in these patients. And so we have to keep them under observation for at least 72 hours and then only discharge them even after complete treatment. And the elimination of phosphorus compounds occur via mainly these three routes: urine, bile, and feces. And what are the implications of route of exposure? Toxic features usually obvious within 30 minutes to 3 hours, and the history of intentional or accidental ingestion can happen. And the routes of exposure are inhalation, skin, and ingestion, which I told you earlier. Inhalation route is the fastest. So that is how the farmers who work in the field using the insecticides, they may feel dizzy and sometimes they faint also because they inhale the fumes that they spray on the grown up plants. And the skin exposure and volume makes it another important route of entry. And the ingestional poisoning is mostly done because of intention to commit suicide. So symptoms would depend on the poison load and absorption characteristics. And the clinical features are, they will be three symptoms like muscarinic, nicotinic, and the central nervous system, which we have described. And the time of occurrence can be acute within 24 hours, can be delayed up to 2 weeks, or very, very late beyond 2 weeks also. And the late presentation will usually present as peripheral neuropathy and weakness. whereas the initial ones will only produce all the other characteristic features of this muscarinic and other things. And they usually describe a mnemonic to remember this muscarinic effects. One is called the sludge, where you get excess salivation, lacrimation, urination, diarrhea, GI upset, and emesis or vomiting. Another mnemonic is dumbbells, where you sweat, diaphoresis, diarrhea, urination, meiosis. That the people becomes very pinpoint in a very severe poisoning because of the acetylcholine excess. There will be bradycardia, bronchospasm, bronchoria, emesis, excess lacrimation, and salivation. So these are the two mnemonics you can remember for the description of the muscarinic effects of this poisoning. And the cardiac manifestation is described in three phases. Phase one is a brief increased sympathetic tone. So that will be tachycardia and hypertension for a very brief period. But by the time patients come to the hospital, majority of them will have only severe bradycardia and hypotension. And there will be a prolonged period of parasympathetic activity with AD nodal blockade, and there will be QT prolongation, which can produce all sorts of arrhythmias also, ventricular arrhythmias. And the mechanism has been due to direct effect on the myocardium as well as overactivity of the cholinergic and nicotinic receptors. And the respiratory symptoms are respiratory manifestation, lot of secretions like bronchoria, rhinorrhea, bronchospasm, laryngeal spasm. And the nicotinic effect leads to weakness and subsequent paralysis of respiratory and oropharyngeal muscles. So secretion and muscle weakness, airway obstruction, and the gastric aspiration, all these things happen. Central neurological depression may also lead to respiratory arrest. So these are the respiratory effects. GI have vomiting, diarrhea, and abdominal cramps. And the neurological manifestation, there may be a paralysis in acute type 1 category, whereas type 2 is intermediate syndrome and type 3 paralysis is delayed polyneuropathy. So you can have it in the acute phase or intermediate phase or in the late phase. All these things produce muscle weakness only ultimately. Management, this is a very short form to remember for examination purpose. First, you have to decontaminate the patient if he has been exposed and he has vomited the thing on his body himself. Then you have to remove all the clothes, give the patient a nice wash, and remove, prevent further absorption through the skin. So decontamination is very important. Then comes the airway protection because of the rhinorrhea, bronchoria. As I told you, there may be severe coughing and hypoxemia will be there. So always secure the airway. And if the patient has consumed the poison and come to the hospital within 1 hour, you can do a gastric lavage if the patient is conscious with a gastric tube and clear all the poison that has been ingested and prevent further absorption. And you can use activated charcoal for removing the further efficient removal of the poisoning. And you can give the atropine or glycopyrrolate to counteract the excess acetylcholine activity that is there. And then you can use ralidoxim or this reactivator of cholinesterase enzyme. This also is time bound. Within the first 4 hours, it will be effective. After that, the binding between the organophosphorus and the enzyme is irreversible. So giving ralidoxim is a useless treatment after 4 hours of arrival of consumption of poison. And patients may need ventilatory support, inotropic support, and then once they have recovered, you can, after diarrhea and other things have stopped, you can start early enteral and parenteral feeding as required to give them the nutritional support. So these are the things, how you do it in detail. And the anticholinergic dosage is very important. You can start with 2 to 5 milligram every 5 to 15 minutes. And initially, as soon as the patient arrives, you give 2 milligram IV bolus until you get the full atropinization and the features are increase in the heart rate, moderate dilated pupils, and dry mouth and drying of the bronchial secretion. And you can then continue atropine. But some patients with the atropine treatment, they become delirious because the atropine crosses the blood-brain barrier and produces a stimulation there. So, if you have any features like that because of the atropine effect on the central nervous system, you can use glycopyrrolate with fewer central nervous system side effects and a better control of secretions. And then the cholinesterase reactivators, there are three main actions: direct reaction, converting whatever remaining organophosphate which has not been attached to the cholinesterase enzyme. Then this pralidoxime will bind it in the plasma itself and make it harmless. Then there is a transient reaction protecting the enzyme from further inhibition. Whichever enzyme which has not been bound to the organophosphate, then pralidoxime will get attached to the anionic site as I told you and prevent the attachment of the organophosphate to the esteratic site. And once the organophosphate has got attached to the esteratic site, then it can reactivate also. So the pralidoxime has three modes of action. It converts the free organophosphate in the plasma to a harmless compound. Second, it prevents the unaffected enzyme by blocking the attachment of organophosphate to the enzyme. Third, it reactivates the enzyme which has already been bound with the organophosphates. So this is the nature of these oximes are it's a nucleophilic agents which cleave covalently the organophosphate and also remove it from the cholinesterase conjugation and reactivate it. The dosage of this pralidoxime is 30 milligram per kg intravenous and the maximum dose 12 gram per 24 hours. For children, it is 25 to 50 milligram per kg. And the signs will be, you see the improvement within 10 to 40 minutes of administration if the patient arrives early. And the side effects of this drug are drowsiness, visual disturbance, nausea, tachycardia, and muscle weakness. So it is available as two presentations, 500 milligram, 20 ml. There are two ampoules which can contain this. So you can give it in a 1 gram dose. And then there is a vial preparation which contains 1 milligram, 1 gram straight away, which are 6 vials available in a combo pack. And recent advancements for the sake, sometimes this question is asked. So instead of using the regular atropine or glycopyrrolate, pralidoxime, if the patient arrives early, and all supportive treatments by decontamination and ventilatory support, then cardiovascular support. In addition to that, they have found that when the organophosphates are used as pesticides and chemical warfare agents nowadays, following decontamination, depending upon the severity, administration of atropine and which causes muscarinic overstimulation and oxime to relax. This is the standard treatment that we have been following all these days. Now, supportive intensive care therapy also we have been doing, including diazepam to control convulsions and mechanical ventilation wherever necessary. Up to this is the standard treatment that has been doing. Now, recently, what they have found is intravenous infusion of sodium bicarbonate, which causes alkalinization, will be effective in preventing the binding of organophosphate to the acetylcholinesterase. That is number one. Second, there is a anti-glutamatic compound called gazacylidine, which has proved to be beneficial along with atropine and pralidoxime and nerve agent poisoning. So, if organophosphates have been given as a nerve agent poisoning as a gaseous agent in the warfare, then gazacylidine will be useful to reverse the neuromuscular poisoning that is happening along with the other treatment that we conventionally do. Then intravenous magnesium sulfate has been found to reduce the hospitalization and improve outcome. And bioscavengers like fresh frozen plasma and albumin have recently been studied to useful therapy to clear free organophosphate. So whatever organophosphate that has not still got attached to the uh, acetylcholinesterase enzyme, they will be removed by this fresh frozen plasma and albumin by binding into them. Then chemofiltration and antioxidants also have been used to remove the unbound organophosphate compound that is there in the plasma. And then recombinant bacterial phosphotiriesterases and hydrolases are also they can transfer the organophosphorus degrading enzyme to a very promising and delayed uh, poisoning. So patients who come very late with features of OPC poisoning, then you can try this recombinant bacterial phosphotiriesterases and hydrolases. Then there is a new drug called Cuperzine A, also revealed as useful effect in post-exposure treatment, mainly to prevent seizures and status epilepticus by blocking NMDA-induced excitation toxicity. And lastly, anti-muscarinic drugs with anti-glutamatic properties, which are available as aprofen, vinasectin, darmifen, which are all active adjuncts to oximes and atropine, which prevents mainly the central nervous system attack, protects the nerve injury. Okay? So these are the two things that you have to remember with regard to treatment for recent advances in the treatment of organophosphorus compound poisoning.
Okay, sir.
Okay?
Yes, sir.
This is mostly the